Welcome to the Chiro Up 15 Minutes to Excellence webinar series. I hope you'll enjoy this final installation, part 7, which deals with hyperpronation. And hyperpronation is literally the foundation for many other structural and functional problems throughout the body. The foot and ankle is really a complex tool. It consists of 26 bones and 33 joints, more than 100 muscles, and it has two really contradictory roles. It needs to be a flexible shock absorber that can contour to irregular surfaces, but it also has to be a rigid propulsive lever. And one of the biomechanical tricks that the foot uses to accomplish this is pronation. Pronation really plays a vital role in the foot's ability to perform these two tasks, and pronation is defined as the combined movement of eversion, abduction, and dorsiflexion, and in that process the longitudinal arch of the foot flattens. In a normal gait cycle, pronation begins at heel strike, and it progresses. The foot continues to flatten through mid-stance, where at that point in time it stops and then reverts back towards supination. So the arch is restored in order to make the foot that rigid propulsive lever in the propulsive phase of gait. There's a safe level of hyperpronation, or pronation I should say, and the point at which pronation stops is called terminal pronation. That's limited by a number of factors, including the bones and the ligaments, as well as the eccentric contraction of the posterior tibialis. Remember, the posterior tibialis muscle is kind of a stirrup that comes up from the back of the calf underneath the arch of the foot and helps to hold that arch up. And it certainly helps to limit pronation. So in a healthy foot, the amount of pronation that should be expected is limited to about 8 degrees. When it goes beyond 8 degrees, then we're going to call that hyperpronation. And hyperpronation causes a lot of repetitive stress. You can see that it's going to cause significant stress on the medial ankle and of the soft tissues of the foot, especially the ligaments. It's going to affect the talonavicular joint capsule, and it's certainly going to affect the calcaneonavicular ligament, as well as the relatively inelastic plantar fascia on the bottom of the foot. And it also allows the ankle to roll inward, and that inward rolling of the ankle stresses the tissues, the soft tissues on the medial side of the ankle. In fact, it places them under traction, and that would include the posterior tibialis nerve and the posterior tibialis tendon. And when those tissues are stretched, we get other problems like tarsal tunnel syndrome or posterior tibialis tendinopathy. So hyperpronation of the foot, when the arch falls when we walk, is biomechanically coupled to internal rotation of the tibia and fibula. And when that happens, that puts a lot of stress up the kinetic chain, particularly on the knee. One of the first things that happens is it causes uncontrolled adduction of the knee. The knee buckles inward, and that puts stress on this medial collateral ligament. It also puts stress on the anterior cruciate ligament, and hyperpronation is a recognized contributor to injuries of both of those. The other thing that it contributes to is you can see this patella wants to migrate laterally, that the normal alignment of the leg would keep the patella in its groove right in the midline, and now that patella is going to be pulled laterally. So that lateral patellar facet is going to be jammed into the lateral femoral condyle, and that's going to be the number one cause of knee pain, runner's knee, or patellofemoral pain syndrome. And these problems keep going up the chain. Remember, the internal rotation of the tibia gets transferred into internal rotation of the femur as well. Well, what happens there is the femoral head is going to be driven backward, and at the same time, the pelvis is going to dip into anterior nutation, pushed forward. That means that the lumbar spine is going to be thrown forward, and for you to keep your body upright, now you have to move the lumbar spine into hyperextension. So now we can see a whole biomechanical chain where the arch of the foot drops. That dropping then puts stress on causes internal rotation of the tibia, puts stress on the knee, causes internal rotation of the femur, throws the femoral head backwards, and then causes the lumbar spine to go into hyperextension. So the other muscle that we need to think about is the hip abductor, that the hip abductor helps to hold the pelvis level. So my gluteus medius being the primary hip abductor on this right side, when I lift my left leg, that needs to contract to keep the pelvis level. If it doesn't, that's going to cause this pelvis to drop, but it's also going to allow internal rotation of the femur. It's going to allow the valgus displacement of the knee, and it's going to cause internal rotation of the tibia and fibula, and then pushing the foot downward. So the same thing that goes up from foot hyperpronation comes down from gluteus medius weakness, and foot hyperpronation causes stretch weakening of the gluteus medius. The gluteus medius weakness then contributes to hyperpronation. So these two are biomechanical co-conspirators. One differentiation we need to make is that foot hyperpronation doesn't just mean a fallen arch or a flat foot. Foot hyperpronation is measured during a dynamic phase, so when the foot is moving, when you're walking, we see a flattening of the foot. These two problems, a flattened foot, pes planus, and foot hyperpronation, can coexist, and they actually, the effects of hyperpronation are compounded in low-arched patients. So what's this patient going to present with? They're going to have symptoms. The body has to employ compensatory mechanisms to offset foot hyperpronation, and unfortunately those corrections don't come without a cost, and the joints upstream need to absorb more shock. So the structural diagnoses that we typically see with foot hyperpronation go from the foot all the way up to the lumbar spine. There really is no typical presentation for foot hyperpronation, but we need to suspect that condition if any of these conditions are present. And the way that we're going to evaluate foot hyperpronation are these four tests. So let's go through them individually. The first one that we're going to look at is what does the foot look like when we observe the foot. So when we look at the normal foot, we should see that the tibia drops down about through the second digit. If we take that plane that projects forward from the tibia and it drops down through the great toe, or sometimes even medial to the foot entirely, we can suspect hyperpronation. Sometimes this is better observed from the rear, and in this case we see the too many toes sign. So that plane of the tibia that would be projecting forward is certainly not dropping through this person's second toe, it's dropping medial to the foot. The other thing that we're going to see is excessive calcaneal forefoot in addition to excessive forefoot abduction, we're going to see excessive calcaneal eversion, which is an inward bowing of the Achilles tendon. And then finally, we're also going to see a loss of the medial longitudinal arch of the foot. One way that we can look at this functionally is through the navicular drop test, and this test is performed by placing a dot over the patient's navicular tuberosity while the patient is in a non-weight-bearing position, just sitting in a chair. And then we take an index card and place that next to the patient's foot on the floor and mark the height of the dot on the index card, and then have the patient bear weight to stand up, and we watch for that dot to drop. Normal drop is 6 to 8 millimeters. If that navicular dot drops more than 10 millimeters, then that test is positive for hyperpronation. One of the muscles, again, that plays a large functional role is the posterior tibialis, and so that muscle is the stirrup that helps to hold the foot up. Its function is noted if we can have the patient perform a heel raise. We're looking for excessive eversion of the foot, and the other thing that we're going to do is to palpate that tendon, and if it's irritated and tender, then we suspect that the posterior tibialis is at least involved. The gastroc and soleus, the plantar flexors, are also often involved in that they insert slightly lateral to midline. So if they're hypertonic, they're going to accentuate the hyperpronation. And so we're going to palpate the gastroc and soleus muscles. We're going to assess their flexibility, and we're also going to look at the hip abductors. So the way that we assess hip abductor strength is by having the patient first perform a single leg stance, and we're looking for a drop in the pelvis. We're going to have them perform a double leg squat and then a single leg squat. And the things that we're looking for are pelvic drop and internal bowing of the knee. If we want to really challenge it, we can have them perform a single leg step down, and we're looking for instability or really any sign of hip abductor weakness, which would be knee buckling or pelvic drop, foot hyperpronation, or lumbar hyperlordosis. And we have an entire webinar on hip abductor weakness that really explains how to assess that, but I wanted to include a quick review here. The other thing that we're going to talk about is the management of foot hyperpronation. So first of all, we're going to make sure that the gastroc and soleus are not forcing excessive pronation because they're too tight. So we're going to strip out those muscles. We're going to make sure that we're looking at the posterior tibialis muscle that originates on the posterior border of the tibia and the fibula. and also somewhat on the interosseous membrane, and then it inserts down on the navicular and the medial cuneiform, and its job is ankle inversion and plantar flexion. And so we often see trigger points develop, and the way that we're going to get rid of those is through some soft tissue manipulation or ischemic compression or myofascial stripping, maybe also contract, relax, stretching. One thing that we want to make sure when we work the posterior tibialis is that we're not hitting the posterior tibial nerve, which lives pretty close there. So if you're doing instrument-assisted manipulation, the last thing we want to do is to stir that one up. Obviously, as chiropractors, we're going to mobilize and manipulate restrictions. The restrictions are common, and resolution of those restrictions are certainly going to improve outcomes. The other thing that's been shown to improve outcomes is orthotics. And not every patient with hyperpronation necessarily requires orthotics. Ultimately, we'd like to train the posterior tibialis to be a functional stabilizer rather than needing an external crutch, but that's not always the case. And in those patients, then their specific needs and their functional demands are going to dictate whether we choose a prefabricated orthotic or a custom orthotic. We also want to make sure that if there's a leg length inequality, that we're putting a proper heel lift in there. One of the things that we like to use is a tensoplast arch wrap, and this can provide a little extra buttressing of the ankle, and you can check out the Chiro Up video for specific instructions on how to create this. It's really quick and easy. Patients love it, and it helps them recover more quickly. There are also commercial options available to help buttress that arch, and this one is a PSC Fabrifoam wrap, which is relatively inexpensive and very helpful. What are we going to teach the patient at home as far as their exercises? Well, number one, we're going to have them do a single leg stance, which basically means just standing on one leg and slowly lowering themselves to the ground while they balance. We're going to perform Valais exercise, where the patient slowly leans forward and backward up against a wall. And these exercises help to recruit the intrinsic muscles of the foot to make them stronger. We know that the plantar flexors need to be of adequate length to be healthy, and so we're going to stretch out the gastroc, and that's going to be performed with the knee straight, and we're going to stretch out the soleus, which we need to bend the knee a little bit in order to incorporate the soleus. And then one of the most important things is we want this posterior tibialis to become a intrinsic supporter of the arch and to function better. So we're going to perform some resisted strengthening by looping an elastic band around the 2 feet and then having the patient rock this foot upward as though they're looking at the sole of their foot against the resistance of the band. And that's a great exercise to help strengthen the posterior tibialis. We need the patient to be aware that they need good arch supports, especially during activity. They should avoid going barefoot. They should avoid high heels, shoes with narrow toe boxes. Patients who are obese are certainly going to have more stress on that foot, and we need to increase activity slowly and following the 10% rule, meaning not increasing your mileage or activity more than 10% on any given week. And as far as how to implement this in office, very simply, you circle foot hyperpronation on your condition menu, send it up to your front desk, and now the patient automatically receives the most appropriate exercises and ADLs to make themselves an active participant in their care. If you wish to review any of the things that we've talked about today, including the assessments or treatments or exercises, simply log into Chiro Up, go to the Sharpen My Clinical Skills tab, and select condition reference for foot hyperpronation. I hope you've enjoyed this webinar, and we look forward to speaking again.